this is our last day and kind of the last session. We have the case competition after this, which is going to start promptly at 12:30. And obviously that's the highlight of the meeting and the opportunity to support our fellows and early career folks that have submitted cases and that are competing. So please try to make it to that one if you can. So with that, I'm going to start the last session, tough cases that build character. Good topic. You made it. So first one is large bore access, and a good friend, Dr. Antonio Gutierrez from Duke. And I haven't seen him, Dr. Banerjee.
I think I'm filling in for him.
Oh, you are? Okay. Jennifer, please. Dr. Remmer.
Hi, everyone. All right, so I'm Jennifer Reimer. I'm one of the interventional cardiologists and also do peripheral vascular procedures at Duke University. Today we're going to talk a little bit about large bore access. It's a really important topic to discuss in order to ensure successful procedural success. So here's my disclosures. So as an introduction, vascular access is a cornerstone, really, of successful and safe procedures. So not a topic that the fellows always love to hear about, but I tell them if you don't have safe and good access to begin the case can be disastrous downstream. So ultrasound guidance still heavily underused. So I looked at some recent data. 13% of providers really use it regularly, but most of your cath labs have it available. So there's a huge discrepancy between the use and availability. So we all know about the complication rates of transfemoral access. Thankfully, relatively rare, but you know that when you have it, it really can cause issues, especially for our anticoagulated patients or patients on a lot of antithrombotic therapy. Hematomas 1 to 5% or pseudoaneurysms, fairly rare. RP bleeds somewhere between 0.2 to 0.5% in NCDR data that's recent. However, as you know, many of these patients go to the floor and unfortunately are not sort of seen or recognized as an RP bleed for several hours, and so there's a heavy mortality or high mortality rate of about 10%. So risk factors, and you know many of us, so extremes of age, extremes of body weight, concomitant issues, especially chronic kidney disease and heavily calcified vessels. Many of our patients are on uninterrupted OAC when they come to the cath lab or to the peripheral vascular lab, are getting G2B3A inhibitors, or may have a puncture at a non-compressible site, or may not have had ultrasound use during access. So a lot of things to sort of stop and carefully think about before you proceed with your case. I would be remiss not to briefly discuss the femoral artery access with ultrasound trial. It's a trial of about 1,000 patients looking at fluoroscopy versus ultrasound with a primary endpoint of successful common femoral artery access. There were several important secondary endpoints, which are noted here, including time to sheath insertion and really number of attempts. And many of you know that really the only subpopulation that had a significant difference between ultrasound and fluoroscopic access was this high bifurcation subpopulation, which is a really tough population to do procedures on, both from procedural access, but also from procedural success for PVI. And then success by experience, and what I want to sort of note is that fluoroscopy had about an 83% success rate, and you can see that by 7 to 10 ultrasound procedures, operators are really at that point of having similar success, and more experience with ultrasound just increases that. For intraprocedural outcomes, number of attempts, first pass success in venipuncture, significantly improved with ultrasound use. The median time to insertion was also significantly reduced with ultrasound versus fluoroscopy. And then vascular complications overall reduced with ultrasound versus fluoroscopy. So overall, no significant improvement in cannulation rates, but this high bifurcation population did see significant improvement. But there was a significant reduction in number of attempts, time to access, risk of venipuncture, and vascular access complications, and a trend to improvement really in all of those subpopulations. But what I really tell my fellows is that ultrasound is really not the only thing you want to be doing. You want to have a good handle on anatomy. So you don't just want to be using the skin crease or the point of maximal impulse, but you want to be using that along with ultrasound and along with fluoroscopy. A lot of times I have to use ultrasound plus the calcification seen under fluoroscopy for access, and I'm really focused on the minimal vessel diameter, the degree of calcification, and the extent of tortuosity. I don't want to hit or access a point where there's severe calcification. And so these images just point out a couple of things I want to bring up. So I see early people using ultrasound, not having the correct, really, angle of the needle with the ultrasound probe. And then with the use of the micropuncture, what I see commonly happening is a little micropuncture wire, especially in my heavily calcified peripheral vascular patients getting into dissection plane. So something you always want to watch and make sure it's free under ultrasound or under fluoroscopy. CTA analysis for planning is also very important. It's key, as was shown here, for understanding the bifurcation height, the degree of tortuosity, the vessel diameter. Many of us have taken care of those little old ladies with the iliacs that are 5 in diameter and know the pain of trying to access those patients. And then to give you a sense of pre-existing pseudoaneurysms. And so to minimize vessel injury and really have reduce issues with downstream distal perfusion, you want to make sure your sheath to femoral arterial ratio is less than 1.05. If you exceed that, then that's when you start to have issues with distal perfusion. I think probably most of us use pre-closure for large bore access. One of the things that I've noticed a lot of people are starting to get in the habit of doing is when you put that 4 French micropuncture catheter in, that's really an opportunity to take a quick picture and make sure you're happy with your access before proceeding. Afterwards, it's really hard once that larger sheath is in, 8 French or higher, to really change your access point, and you could be really dealing with a huge issue in terms of bleeding and difficulties with getting your bleeding under control if you don't stop at that point. So this is just a look at that, quick pictures here. And then I want to talk a little bit about closure techniques. So I mentioned the Perclose. I think that's what predominantly we use for a lot of large bore access closure. Manual compression is really not ideal. Difficult to get control of bleeding. You're going to be standing there for a long time. And with patients being therapeutically anticoagulated, in a lot of these cases, not a great way to try to end your case. Assisted manual compression with a thumostop is oftentimes used. And I've had to occasionally use this dry closure, which I'll show in the next slide, which is the crossover balloon occlusion. So it's an access bailout technique. You get contralateral access with a 6 French or 7 French sheath. And then you can advance, you can use an Omni, which I typically use, or an IM catheter to get over the wire access to the site where you need to get control over bleeding. And so then essentially you just take a peripheral balloon, blow it up proximally to the area of the sheath to try to get sort of hemostatic control. Coda balloons also can be used. I think the biggest thing I would say here is just make sure you know what is available in your lab, where it's located, because these situations really necessitate you being able to get that equipment very, very quickly. So final thoughts. Planning is really key to success. Think about CTA, obviously. Think about pre-close. Many times patients come from outside hospitals without pre-close on their Impellas, and it's very, very difficult to manage those patients when they have bleeds or they have distal perfusion issues. Use ultrasound and fluoroscopy and your knowledge of anatomy. And then we've talked about some strategies for bailout with dry closure. I'll take any questions. Thank you so much.
I think we will have time for questions. I think we are running right on time, so let me invite my dear friend, Dr. Constantine Pena, who is an expert in both arterial and venous revascularization, and he will present some tough cases that build character regarding IVC occlusions.
Great, thank you very much. These are my disclosures. I think when you're looking at IVC occlusion, I think really the first question that you should ask yourself, is it an acute or a chronic occlusion. And their treatment of both of those are going to be a little bit different. I chose today a chronic occlusion, but maybe afterwards we can talk a little bit about what an acute occlusion and how to manage that. The case I'm going to present is a 54-year-old man with progressive back pain and leg pain who's worsened over the last 6 months. Pain is aching quality, tends to get worse at the end of the day after extensive physical activity. And basically, he has a history of rheumatoid arthritis, and he was a construction worker, and he had a history of a previous DVT years ago. And during his evaluation for his back pain, they had a lumbar spine MR, and on the lumbar spine MR, they found small amount of degenerative disc disease. But when they read the MR, they saw and they told them, we don't think somehow you have an anomaly. You don't have an IVC. And you can see here the actual images of what they were seeing, and that's basically what he was labeled, that he didn't have an IVC. Followed up, then he came and his primary care physician saw him with his back pain and said, I think there's more to this. This may be explaining why you're having this back pain. He had a CT scan, and you can see in the CT scan that you see the aorta, then you see what seems to be really small little vessels along the retroperitoneum. And on reconstruction and coronal views, you see almost like this small kind of a linear area that comes up, and you start seeing a suprarenal IVC, but you don't really see an infrarenal IVC. And a patient was referred to evaluate, well, maybe this is what's going on with his back pain. So our findings here in the CT, chronic IVC and bilateral column and iliac vein occlusions with extensive varicosities, with enlarged lumbar veins and an enlarged azygos vein. And we basically classified them as chronic DVT. And you can see on some of that, on CT imaging, there's even some calcification in the external iliac vein. So, what was our treatment considerations and what's the discussion? And, obviously this patient had, when you talk to them, hey, what happened and when was your DVT? And in this particular patient, it was about 20 years beforehand, and discussed with them exactly, and really teasing out what their symptoms are. I think it's critical when you see a patient like this, are their symptoms really related to what's going on here? If not, maybe not to do much in terms of treatment. But in this case, we thought that his back pain and really what was going on was related to these varicosities and the fact that it was back and leg and worse at the end of the day. So at this point, we decided maybe we can do an IVC reconstruction and discuss with him that procedure. And usually when I apply and start doing these, we go with bilateral common femoral vein access as well as an internal jugular access, so from above and below. And you can get an idea here as we usually start with bilateral common femoral vein access and go ahead and perform a venogram, and you see what we're dealing with here. And you can see all the collateralization. And as soon as you start seeing the size of these collaterals, you get an idea of, hey, this is really chronic. Patient probably has this going on for a long, long time. And I think this is always a challenge, because as you start creating the IVC or reconstructing the IVC, you're going to basically have to challenge all these very well-established collateral pathway to be really the primary source of blood supply or the more inline flow back into the right atrium. As we start recanalizing this, and I like to have that view that I showed you there. Take a look. First of all, the CT is really important. Get an idea from the CT scan, how long is your occlusion? Where do you see the vein coming back? What's the nature of what's left? I almost thought that I saw what was left of a little bit of an IVC, that little kind of linear area that I pointed out with that red arrow. And I said, if I can get into that, I can probably then dilate everything up. And I think that really adds to how well you're going to be and how successful you're going to do. A lot of times I'll start with a catheter and a wire, but I'll quickly move to a Triforce catheter. A Triforce catheter basically goes through a sheath, so I use a sheath for support, usually a 7-French sheath. This is a 5-French catheter that has almost like a CXI type catheter in it, which is reinforced. So that 5-French catheter that it goes through, so a 7-French sheath, 5-French catheter, and then almost like a CXI catheter through that. And I'll use most of the time either a glide wire or a Roadrunner wire, which has a hydrophilic wire with an 018 tip. And I'm really just wanting to see where this 018 tip wants to go and see if I can get it to get into one of these veins. Obviously, just like when we're dealing with recanalization in the arterial tree, these collaterals make it difficult, right? If you have a collateral, your wire wants to go in the collateral. So you kind of have to kind of force it using an angled catheter and what have you to try to define this other pathway. And you can see here doing that and trying to get at least one of these wires to go up into the IVC. And usually I probe both sides, trying to find one of these that's going to go. And this is why I think the IJ axis is so important, because it gives you an idea where you're going, okay? And then it's important here in this type of technology and techniques to use a lot of obliques. You kind of oblique back and forth. It's very easy that you may get into a paraspinal vein. You don't want to be digging in that area. So I kind of use obliques to figure out, am I going too posterior or not? You can see here, again, driving a wire and catheter and then trying to establish that access. In this particular case, I was happy that I was able to successfully kind of recanalize the right iliac system and then went to fight with the left. And once you have one side, it makes it easier because you have a kind of a target, and you can see us there. You can see that long, dark area is the tip of that 5 French sheath catheter type system, and through there you have like a CXI catheter, and then what you're seeing probing there is with the 018 wire. And again, I think what we all have learned is that tricks that we learn from one area, we apply somewhere else. And this is something that I think this is why multi-specialty and all this stuff works. And we already know if we can use a balloon, sort of like a cart type technique, it's helpful. So that's exactly what I did in this case. Blew up a balloon in that right iliac vein type system to try to see if I can create a better dissection plane and finally able to recanalize and get the wire to go. Once this happens, one thing that I've done, which I think is very helpful, is I'll go ahead, position my stiff wires, and then I'll have a cone beam CT. And really what I want to see in this, with this is, are my wires in the correct location? They're not paraspinal, that they're where I think the native cava should be, and that gives me just another sense of security before I start dilating. At which point then I start dilating. Here go venoplasty. I went to 10 millimeters and then placed self-expanding stents. And traditionally I've been using this double barrel technique. Mahmoud Razavi quoted a paper that just came out in JVR using what they call a skip technique. So now that we have bigger diameter venous stents, putting one of those in the IVC and then placing smaller self-expanding stents in the iliac veins, and maybe even leaving a little skip area in the proximal cava. But you can see here going to 12 and 14, and this can sometimes be very painful for the patients. I still like to keep them sedated, but I like to hear how they're feeling, because I know it's going to hurt a little bit, and I kind of gauge that to know how fast and how quickly I go. I do not go quickly right up to 14 French. I kind of go to 10, 12, place the stents, and then dilate the stents gently and go from there. And you can start seeing now that you're competing against these collaterals, and you start creating inline flow, at which point, in this case, I extend a little bit superiorly. I like to stay away from the renal veins, and here's our final image of basically recanalizing an IVC occlusion using a double barrel stents. And you can see with a CT the importance of having these not covered stents, because a lot of times one of these stents will be the bully and take over the other one. But as long as they're open cell and self-expanding stents, the flow is still, they don't compete for flow. So thank you very much.
That was a beautiful step-by-step, great case, and we learned so much from this kind of case presentations. Really appreciate it. The next presentation is going to be Dr. Goodney, and this is a tough case that builds character, bailing out my interventionalist.
Great, thank you very much for the privilege of the invitation. It's great to be here again. So this is a case that we took care of just a few months ago. No relevant disclosures. So I'm a vascular surgeon at Dartmouth-Hitchcock Medical Center. I was just minding my own business. I had finished an iliac stent, and it was my daughter's birthday the day before, and had sort of a pretty bland afternoon ahead, and that's how most good stories start. And they said, can you come to Cath Lab 6 right now? It's sort of right down the hall from our endovascular operating room suite. So I grabbed the fellow. I said, let's go take a walk and see what's happening. And when I walked in, this is our combined structural heart suite. So it's a nice big room with all the usual fancy toys. And every cardiologist I ever met at our institution was in there at the time. And there was a little bit of chaos going on. And they turned around and said, well, Phil, don't worry, it's not too bad now. I think we can stop doing CPR. He's at least alive again. I said, well, that's good. Why don't you tell me the story? And so the story was, this was a 78-year-old gentleman who had critical aortic stenosis, and they were putting in an Edwards C3 device, which is shown in the left-hand corner of the panel there. And you can see they kind of got the device up to the end of that sheath, which is coming from the right common femoral artery. If you could loop that video again, that'd be nice. But something happened when the device came off out of the sheath, that it kind of got hung up in the distal aorta or in the iliac, and then they couldn't pull it back. And then all of a sudden he became hypotensive, and a little bit of chaos ensued. So now they had a hypotensive patient. They had a balloon up proximal to all this, but they had a device that wouldn't come out, and his blood pressure would stay relatively okay as long as the balloon was up, but even then it started to get a little bit soft, and they had pulled on this device as hard as they could, or at least as hard as they were willing to pull, and then called for our assistance. There wasn't really a whole lot of choice here. He was sort of intermittently getting CPR and compressions, and so with that I just said, well, there's not a lot else we can do other than just pull hard and see if we can get this out and then fix whatever's left. So we pulled really hard, and eventually the device came out, and with it came the right iliac artery and what I thought was probably the distal end of the aorta, too. I won't have any videos here because at this point things had gone a little bit from bad to worse, and I wasn't really thinking about case presentations. But as with all things, you take a deep breath and say, well, now what are we going to do? And fortunately, we had coda balloon up from the left, and I thought Dr. Reimer's point earlier was a good idea. If you could make this one loop again as well. I knew we had good solid access from both groins, or at least good solid wires, because the TAVR device was going to be traveling over it. And if you could loop it one more time. You can see here the coda is sitting well below the renals, and there's aorta at least above that, but I wasn't really sure what was below it and how much of either iliac was still intact. And I thought, well, I don't want to fix one iliac and find out that the aorta is still missing in between, so I thought we would just put a bifurcated EVAR device in. So while I stood there and made sure that the balloon didn't go anywhere, I sent our fellow, Dr. Sadia Ilyas, I said, you're going to go plan the quickest endograft you ever did, so go measure this and find out what we need to get this a bifurcated device in here. And so she did a good job in doing that, and our team rallied pretty quickly to get us what we needed. And then on to the next slide. As you know, EVARs have two legs, and so we did sort of the dance and balloon trick where we had balloons from either side and then placed the EVAR. This EVAR is now infrarenal, and Sadia cannulated with the balloon up. She managed to somehow cannulate that gate on the left side. And then I said, well, I'm going to drop this balloon for about 10 seconds for you to get the stiff wire up there, and don't let anything slip out when I do. And she did a fantastic job of getting us, again now, secure access from both groins with the EVAR device planted well below the renals, but also well solidly seated in the aorta. And at that point, I sort of gave a little sigh of relief, because now at least it seemed like we had a pathway home at this point. Next slide, please. And now, as with all things in vascular surgery, proximal control is kind of our mantra in terms of making sure that we have enough control for blood pressure. And you can see here, now the EVAR device is seated well, and on the patient's left side, it seems like there's native iliacs, but on the right side, there's just kind of retroperitoneal, whatever that is, sort of place for the blood to run out to. And it looked like it was still a little bit troublesome, and there was bleeding around the sheath on that side. So, at this point, the coda was sitting inside the device, not inside the native aorta, and seemed to be pretty steady. So I thought we had some time to work on that iliac on the patient's right side. Next slide, please. Now, given that we could see here, there still was evidence of what we describe as bleeding from the absence of the iliac artery on the right, but we thought if we just extended down towards the groin that we could probably control most of that. On to the next slide, please. And as we say in New Hampshire, you got to get from here to there, and now you can see with a whole bunch of Viabonds and some iliac stents, we now extend all the way down to the bottom. Now remember, if the iliac came out on a stick, the iliac has a proximal part and has a distal part. We had to cut the distal part off of the common femoral artery, so the ripped out end of those stent grafts have to get sewn onto something. So that's what we did here. You can see on the left of the panel is the patient's head, and on the right of the panel is the patient's feet. And if I'll play the video here, you can see there, I'm just very briefly going to give you a peek at those iliac stent grafts emerging from the retroperitoneum. and we sewed a little bypass graft to the residual common femoral artery that had been transected when the iliac came out. And so now, really, the only thing we had to worry about was whether the end of the hypogastric was going to sort of ooze a little bit at us. But as you can see, there's not a bunch of red blood welling up from that hole, so that made me happy that day. It seemed like with a reversal of anticoagulation that managed to stop. This is what he had a sizable retroperitoneal hematoma for a few days and spent a little bit of time recovering from all this. But the completion scan, fortunately, didn't show any bleeding in the next couple of days, and he went on to get a surgical AVR a few days thereafter. Overall, ultimately did well. So, in conclusion, this, obviously took a tremendous amount of teamwork from both our teams, our cardiac and structural teams, and a little bit of luck doesn't hurt either. So I'd like to thank you for the privilege of the invitation and look forward to the discussion.
Thank you, Phil. I think our character is being built as we are looking through these great cases. And invite Dr. Yolanka Castro from University Hospital in Case Western to give her talk on R2P, starting with the abbreviation.
Sorry. Good morning. Thank you, everyone. Thank you for the opportunity. That was a fantastic case. My case is also built a lot of character in me, but not like that one. So I have a case about radial to peripheral. We start with a 76-year-old woman with a history of coronary artery disease, prior CABG, PAD with multiple stents, including bilateral iliac and SFA stents. And even more recently, a year before her presentation, she had a CIRAP procedure with biiliac cover stenting and aorta stenting as well, who presented to the ED with left foot pain and coldness for 7 days. That was getting worse, reason why she came into the ED, in the setting of anticoagulation interruption prior to a routine colonoscopy. Her medications were supposed to be clopidogrel, Xarelto, and atorvastatin, but both her clopidogrel and Xarelto were held prior to her colonoscopy. On exam in the emergency room, she had decreased femoral and popliteal pulses on the left. Her foot was pale and cool, and she had non-palpable pedal pulses, but no wounds. And in the ED, they obtained a CTA that showed an occluded left iliac and SFA stents, reason why we took her for an angio. So we did this via right radial access. We placed a 6-French 119 centimeter R2P sheath. And as you guys can see here on this angiogram, we see how the right iliac is open. This is a prior CIRAP procedure. We have a distal aorta cover stent and also biiliac cover stents as well. And we see how the entire left iliac system is occluded with distal reconstitution in the distal external iliac, and the CFA is open. So at this moment, we were able to cross without major difficulty with an 035 microcatheter and a 018 wire into the CFA. We confirm that we're intraluminal with a distal angiogram. And then we take a couple more pictures. We see that SFA stents are totally occluded all the way down to the pop as well, with distal reconstitution in the distal pop. So at this moment, I decide to do angiogenetic thrombectomy. I like to do, when I see that high amount of thrombus and all that clot burden, I like to do pulse spray TPA. And basically, I did a couple passes and I do 30 minutes of dwelling time with the TPA, and then multiple passes. The initial image was before the TPA, and the following image is after that dwelling time and a couple more passes. And I see much improved flow in the iliac stents and significant disease past that external iliac stent. So my decision is to perform a balloon angioplasty. I placed an additional self-expanding stent in the distal sternal iliac. As you guys see there, I have a filter. I didn't mention that. I do have a filter and in the common femoral that I placed before doing my pulse spray TPA. And then I just started doing some balloon angioplasty, but then I take my picture and the flow is not so good. So I'm like, oh, maybe my filter is full. Let's retrieve the filter. Let's see what happens. So I take my 035 microcatheter and then try to retrieve my filter, but it's not coming back. So I'm like, okay, what's going on? Then I see when I'm trying to get my filter into the 035 microcatheter, I see the filter comes back, but the stent also wants to come back as well. And at this moment, okay, I do not want to push. And I call my friend June. I'm like, what do you think, June? What should I do? So at this moment, I decide maybe let's try to see if we can get this from the distal and retrograde. So we access the common femoral and see if we can snare from below. But we were not able to snare from below. And at this moment, I'm just like, let me try to pull again. And we were actually able to pull, as you guys see on that last image, pull the filter. And there's a small distortion of the stent distally. And then at that moment, in order to repair that, we place another self-expanding stent in that area and do further post-dilation. But the flow is not good. Then I'm thinking maybe it's our outflow that's a problem at this moment. So we proceed with doing more, remember I'm from radial at this moment, so I just proceed to do more dilation of the SFA and POP at this moment. My flow is better, much improved. Thank God for the TPA, but still there's a lot more work to be done, but at this moment it's like probably almost 4 hours into the procedure, so we're like at this moment we should stop. You know, she has her foot, she's not having pain at this moment, she's feeling better. Let's stop and bring him back to address the rest of the disease. So next day, we actually go from a brachial axis, because we know we have to go more distal and try to attack more of the distal disease. And 85 centimeters RTP sheath at this moment. And I see there's still there's improved flow. You know, we did live in our heparin overnight, but there's still some clot in the left common iliac. And there's some disease as well in the SFA. So you guys can see some slow flow, and all the stents, there's still a significant amount of clot there in the distal SFA stents, and as well as a POP. So at this moment, I proceed with penumbra aspiration, and after doing multiple passes with that, I get much improvement in the flow, but there's still significant disease, especially more distally at the POP. So, since this is one of the most expensive cases in the lab, we actually go and do laser atherectomy in the iliacs as well as the SFA POP, which actually helped a lot, especially, I think, there was an area of likely ISR in the distal stents, and definitely doing a laser atherectomy helped with that. Okay, and after this, multiple balloon angioplasty, drug-coated balloon angioplasty as well, including all the way up to the common iliacs. And this is our final angiogram. There's still some residual clot in the common iliac. I don't know if you can play those, so there are two pictures are supposed to play. Good. But much improved flow in the SFA. Her foot exam was much better. She had no pain. And the last, if you can play that, please. If you can play that third, yeah, perfect. A much improved flow with that much better runoff, with 3-vessel runoff at this moment. At this moment, we decided we're good. She has improved flow. Her exam is much better. There's still some residual clot, but it's minimal at this moment compared to what we had before. Pain-free, improved exam. She was discharged from full dose Xarelto and Plavix and doing well in follow-up. And we can see her ABIs are normalized at the on follow-up. Learning points for me, know when to stop in some cases and come back another day to triumph. Always remember the limitations of your access. And if something gets stuck, do not panic. Thank you.
Great, thank you, Dr. Castro Dominguez. We're going to invite Dr. Tarek Hamad. He has an aortoiliac complication. Subhash gave all the complications from my institution. Thanks, Subhash.
Hi, everybody. Thank you again for the invitation. A better title probably would be not to turn a simple case to a more complex one. So brief history, 55-year-old, very complex, bilateral CAA, remote cabbage, diastolic heart failure, severe LVH, COPD, 2 liters of oxygen, kidney pancreas transplant remotely in 2009, who was transferred from outside the hospital for management of CLI. His presentation was severe ischemic rest pain of his right leg along with a heel wound. The very last line, actually, we didn't have the info at the time before my first intervention, is the podiatry evaluation. So I'll skip that. That is how his right foot wound looked, extensive as you see, probably, osteomyelitis just from looking at it. And his PPR testing is the right side, damped PT and DP waveform, and the flat TBI 0. So like we almost always do, if we don't have a CT to plan, we just go up and over from the left, CFA, ultrasound guided, fluoro guided. I don't know if you can appreciate, but the aortic bifurcation angle is very acute, so you have to use Omni and Woolley to engage the right common iliac system. In the first panel, the iliac system mild disease, except for the proximal segment of the external iliac, has severe disease. I think probably underestimated the lesion visually initially. The CFA in the second panel, heavily calcified mild disease. Profunda has moderate severe disease, OSLI and med. SF is occluded. Third panel, SFA comes back midway, distal way, and has some moderate diffuse pop disease in the last panel with some infrapopliteal disease. Whenever I fix iliac, we always take picture of the obturator system to make sure the internal iliac is okay. Actually, the internal iliac is occluded here. Artially, as you can see, there is a large AV fistula, and there is also the kidney. Remember, he's a guy with a kidney transplant, so his kidney is attached to his left external iliac artery. So, I want to play smart, so I thought, I was not sure if I'm going to have enough working length coming from up and over, because the lesion, although it's in the proximity of the external iliac, is very close proximity to the aortic bifurcation. So I thought maybe I would advance the sheath with the dilator through the lesion and then come back, pull back slowly. And guess what? I got stuck. After I removed the dilator, I tried to come back with the sheath, would not come. And the aorta is very calcified. You can see, and this actually does not tell the story. Every time I pull the sheath, the whole aorta move. Thankfully, the patient didn't have any pain. I tried to advance the sheath. Maybe in the third panel, you can see that actually the sheath, instead of tip advancing, the kinked part goes up in the aorta. So I didn't know what to do. I tried to put the 035 dilator wire back. Maybe I put the dilator, manipulate the sheath. The wire would not go. I think the sheath at the bifurcation level is severely kinked. I tried to put even an 014 wire, and they didn't go. I tried to support with the XI microcast, it didn't go. So this time I got an ipsilateral access to the iliac lesion. I put a 5-French sheath. I put a woolly wire rendezvous inside the ancel sheath, a contralateral one. Then I put an IM, and I pushed the wire and the IM inside the ancel sheath. And since that part is kinked, so the wire and the IM would not go beyond, so it helped me pushing the IM as I'm pulling from the other side. And this way I was able to, to retrieve the sheath, proximal the lesion, and proceed with the intervention. I took a quick angiogram just to make sure no perf, nothing major. And then proceed with IVUS, pre-balloon, pre-DIL, stent. I think I put a 10-0 by 40, I want to say, IVUS guided, and post-DIL. I think the vessel was about 8-0. I oversight by about 1 millimeter, we always do. And post-DIL, and this is a final picture on the right side panel. So here's our access sites. The initial one where the kidney transplant is totally occluded. As you see, the sheath is occlusive, basically. And then the left side, the SF is occluded, also disease CFA. So we decide for the left just to do vascular with manual pressure, and for the right to do manual pressure. And we always, honestly, for this intervention, iliac, and in general, we give protamine to reverse. ACT was high to reverse, and especially if we're doing manual vascate. And guess what? 2 minutes later, patient became hypotensive. He went to BRS, chest compression, epinephrine, and now what? So there was a lot of, it was a quick 1 minute, but there was a lot of tension in the room. I had 2 fellows, one about to graduate, one it just started, and all of them tell me, oh, let's go up and over, let's get access, let's rush, let's do it. And honestly, I was very confident because patient throughout, as I learned in my fellowship, most important to ask the patient, and whenever we go with the balloons, the iliac, we always ask about pain. Patient has 0 pain throughout the procedure. This was IVUS guided. I was very confident, very, very confident that this is not an iliac perf. I asked, hey, can we stop the protamine? They told me protamine already done, finished. This was 2 minutes of procedure. So this actually made me more comfortable. This probably protamine reaction. So we gave him, the steroids, epi, antihistamine. came back 10 minutes later, coded again. Hypotensive, PE arrest. And they still insisted no access. So we actually just supported him with levo, vaso, put him CICU. He got transferred, he had to be intubated for his airway protection, went to the CICU in levo and vaso, swan placed, number consistent with anaphylaxis. His CV was 5 despite all the pressures, all the IV fluids. Second day came off pressures, no CT or CTA was done. This was very clear instruction to CICU, there's no need for any imaging studies. And we brought him back. By that time, podiatrists saw him and they said, you know what, the foot is not salvageable, but the team who's gonna perform the BK felt better if we do the SFA because the profunda, as you know, had moderate severe disease. So brought him back next Monday, I think the 15th, we fixed his SFA. No more ischemic rest pain. He's from far away, so we didn't follow him up, but I know he underwent the BK on the 15th of June. I just reviewed the chart. So just protamine, keep in mind, you know, it can cause hypotension by 3 different etiology, vasodilation, direct or indirect, severe anaphylaxis, vasoplegia, or actually sometimes RV failure because of acute vasoconstriction of the pulmonary artery. So take-home message, I think first one I didn't write down is just don't advance through the sheath through the lesion, especially if the lesion is tight. I think I underestimate the lesion. Second, you know, honestly, now thinking back, I think probably I would have better performed everything from the ipsilateral side and not to even put a sheath with that transplant kidneys. Third, always do IVUS. I always do IVUS for early intervention, for sizing and for safety. Fourth, you know, slow infusion of protamine over 10 minutes. And honestly, the best practice, I know we all rush, but the best practice probably to keep the arterial sheath in place while you're infusing the protamine over 10 minutes. Have differential for hypotension, be ready. Up and over is not always the answer. And know how to manage anaphylaxis on medication doses. Thank you so much.
Great job. Great job, Tarek. And great cases. You know, I'm just going to have a little bit of a discussion. You know, there's so much to learn from these cases. I want to go back to that aortoiliac complication Dr. Castro-Dominguez presented. I'm going to start with Dr. Goodney. When you have, and this is a very, very important lesson, very, very important lesson in my opinion, and I feel if you can help us with this. When you have aortoiliac disease, and it extends to the groin, to the common femoral, which artery is more important, the profunda or the SFA?
The profunda. I think it's...
That's a very, very important point. And can you explain why the profunda field? Can you explain what are your concerns about, the future of that patient per se?
I think, I often counsel the patients in clinic who get referred with an SFA occlusion and a robust profunda, and I said, look, your body's already made enough pathways to more than make up for the blood that was flowing through, sort of the superficial femoral artery. So especially when there's profunda orificial disease, and that was a nice image that was shared during that case, and I enjoyed reviewing that. But the profunda, especially with distal external iliac artery disease, being sort of careful about where you're ending your angioplasty and stenting and making sure that dissection planes don't go knocking into stuff. It can really make for a long evening if you take somebody who is profunda dependent and then shave it off with a dissection or something. So we have a pretty low threshold to revert to surgical treatment when you have a critical stenosis that involves the profunda origin, because there's just too many chips on the table, if you will.
That's great. I think the toughness of our character in these situations are not just edified by the dramatics of the case, but more so by the dichotomy of decision-making that happens in the minds of the operator. I think our presenters have done a fantastic job sharing this. And I hope you don't mind if our discussion goes over a little bit and we go a little bit into lunch, because this is a fabulous session. So I have a question for my two panelists. The credentials of Dr. Bala Ramanan is that not only she is an excellent vascular surgeon, she has dealt with my complications for over a decade. And the credentials for Dr. Abu Fadl Mazen, another panelist, is that he has actually written the book on complications. So Bala and Mazen, a question for you is that I have a sheath, and I'm sure this is in the minds of many of you in the audience, I have a sheath or a device stuck in the iliac artery through common femoral. So it's a very simple question. At what point in that case would you like to be called? So should I tug and try to get it out? Should I get contralateral access and get a balloon up? Because I think that is a very crucial question. And I think or I should try to do and then start placing viabonds and then call you, I'd like you to emphasize that. And the question from Mazen is that from your book, can you identify some very simple predictors that would lead us to believe that this is a case that something like this is likely to happen? So start with Bala and then over to Mazen.
So that's a very interesting situation. And that happens to all of us, having devices stuck in various arteries. But I think the first thing to do is you need to have personnel available, extra people to help. Second, if it's you think you may need a vascular surgeon, I think it's always better to call when at the beginning, before you start having, say, uncontrolled bleeding.
Before you start doing CPR.
That would be preferable. But I think it's important to call for help early so that both of you can work as a team to figure out what are the next steps and to kind of go through the algorithm of what we would do together. The third thing is to have devices available to bail out before we start doing something like tugging on a device. Because the expected, the outcome that can happen is getting an iliac on the stick or, a complete disruption or a rupture of even the aorta, as happened in Dr. Goodney's case. And in those cases, we need to have devices to bail us out. And sometimes those are not readily available. And sometimes we have to call device reps in. So before we do something like tug on an artery and pull a device out in an uncontrolled fashion, I think we have to have all the devices that we think we'll need, the personnel that we think we'll need, and preferably call for help as soon as you recognize that there is a problem.
Yes, thank you. So thinking about sheath entrapment, I think about a few things. The vascular bed that you're in, we've all heard about radial and, sheath get entrapped because of spasm and stuff. Other things I can think of and unfortunately experienced is tortuosity. I'll give you a quick example on things I say. For example, I had a patient that was dying to do a left radial and had an axillofem bypass, and the vessel looked like an M where the bypass was because it was kind of pulling down, and trying to navigate this to go. And same thing with bad iliac tortuosity, and then sheath don't like to take all these tortuosities. They again can get stuck. Obviously, severe disease and calcifications would be the worst one, especially we lose stents in the periphery, we lose stents in the coronaries because of calcification. They grab on equipment, and same thing can happen with the sheath. Again, a quick example, because it can be helpful. I was going up and over, trying to get trying to get just a pigtail across. Iliac, very calcified and tortuous, and the pigtail got stuck, and the pigtail would not come back. I pulled hard, and the pigtail got cut, and like 10 centimeters of the pigtail were still stuck in the lesion. So I had to get access on the other side. Thankfully, it was still over the wire, get the wire snared and out, and put a sheath and a dilator and push the pigtail piece all the way out. So if that happens with a small pigtail, you can imagine what can happen with big sheaths. So these are the things: tortuosity, calcification, spasm, and bad disease.
Thank you. And maybe a review of the CT of the pelvic anatomy that Chris Metzger identified before, I think could be very useful steps to avoid such complications. Thank you.
Yeah, the one other thing I would add is that has happened to me a few times, when the sheets get stuck, especially in tortuosity, is if you're pulling from the end of the sheet, it will avulse from the sheet. So pulling is usually not a good, response to these situations. But if you're gonna pull from the skin and not from the end of the sheet. So the sheet separates, now he's bleeding, and he's not coming back, and he's bleeding, and he's trying to deal with all of that. So actually, I think we can have a session on complications of, seriously. So let me ask Drew one question. Drew and also Jennifer, the two of them, Jennifer did a great job with the large bore. What is your recommendation, when a lot of times, we are called into these procedures, like Dr. Goodney, where our colleagues that are using these large bores for structural or other procedures, they get into complication and they call us. How do you manage when you called into the room, there is chaos, and what are some of the steps that we should take into consideration dealing with this kind of a situation?
So that's a great question, Mehdi, and I think the key things is just staying with principles. And so in a surgical principle is gain proximal control. And so you have to gain proximal control when there's a bleeding issue. Coda balloon is a great idea to just make sure you have it, and hopefully it's in your, we call it a structural heart interventional trolley. You can look at the algorithm there. So it's on our structural heart interventional trolley for large bore access for Coda balloon. And then also, in addition, just making sure large bore access is there, making sure that they have IVs and very basic resuscitation efforts. And so what I usually do in those situations is try to reach for the Coda balloon. You have plenty of access, but in addition, making certain that you're delegating people to get blood and make sure that you have IV access. If you need additional venous access, it's always helpful. So stabilization is number one with proximal control, and then aggressive volume resuscitation. And I think us as internal medicine trained, we never really get that trauma training that our surgeons have, and it's really in that first couple minutes that you really have to be very aggressive about volume resuscitation, or else your patient can get behind the 8 ball and die.
I think that's some really great points. I remember I'm now about 3 years on faculty, but I remember my second month on faculty in the middle of the night, coming in for a coronary for STEMI, had used all radial access, fixed the large anterior STEMI. Patient was in shock. So at that point, via hemodynamics, decided to just do a balloon pump at that point. Unfortunately, very tortuous iliac system, and had a distal aortic perf. So I would say, you have to stay calm, but you have to know where your equipment is. I knew exactly where the Coda balloons were in our lab, because those are really things you have to get within seconds. Vascular surgery, call them obviously immediately, but they're not in-house sometimes at night, and so you have to, the fellow may be, but the attending may not be. So you have to know, you have to keep calm, you have to know what to instruct the nursing staff to do, your fellow as your side hand, but then get control of the situation with balloon occlusion until you can get help. And just to know how to sort of take your own pulse, divvy out and delegate, but ultimately these types of things I think are oftentimes, when I've seen it gone disastrously in my short time, is when we don't know where our equipment is, and you're running around trying to find covered stents, trying to find the balloon occluders, things like that.
That's great advice. I mean, I personally feel, and I've been through this myself, I think when we have a complication, our flight and fright kind of system kicks in, and you think that I need to quickly get out of this situation, and that's probably the worst thing you can do. The first thing to do is to stabilize the situation so you can think. The second thing probably is to call friends to come and help you, because you're under so much stress. You need somebody to come, as Chris Weiss said, somebody that is not really vested, will be vested, but is not vested at that moment, that can come calmly and have a discussion and think of other strategies to get you out. So the Coda balloon, definitely for aortoiliac and some of these cases that we do, large bore is a great idea. Okay, I'm going to go to the SFA calcification with Dr. Klein.
Thanks, Mehdi. I'm going to try to, perhaps maybe the best way to take a complication is not have one. Let's see, I'm going to give you some tough cases, 3 times the charm for femoral popliteal. Some cases on how to handle the calcification that we all deal with on a regular basis. So welcome to the Rock, and let's get started here. Hopefully our thing. First of all, I'm an interventional cardiologist. If you haven't seen this slide, thank you to Chris White and James Hermiller with this. So I have a very small brain, and that brain has very little survival mechanism, but a huge oculostenotic stenting and dilatation center, and a very small intelligent thought and evidence-based medicine fashion as well. So I think life lessons here for SFA calcification is pre-procedural planning is critical. I do CTAs prior to everything, so I need to know what I'm going into. It helps me have informed consent with the patient, either CT, MRA, or duplex or something. And that allows me to understand access and what is the time I'm going to need to do this case. And so I think it's important, especially with SFA calcification, we all know that, is it mild, is it moderate, or is it severe, or is it off the chain? And you really need to know that. Also, it tends for your access as well. Are you going to come from above, below? You're going to do antegrade. And I think pre-procedural planning is really the best. And really, Sun Tzu really said, know yourself, know your enemy, in 1,000 battles, 1,000 victories. So know what you're up against. So here's a 64-year-old gentleman with CAD, usual stuff, claudication, 10 years, now left heel wound, ABI, terrible, SFA calcification. And so if we can play these, it would be great. There's basically it's a stumped off SFA, and this is every day in the office for all of us, right? And this is just a rock with a lot of heavy calcification. I don't know if that's going to play for us, but essentially reconstitution.
Can you, one second, can you please play those images for us? Thank you so much,
The
our
next
AV team.
Okay.
Oh, they're not playing? Okay,
Okay.
thank you.
So this is a case where I think I've seen Subhash use ultrasound for this and really understand where you're going for your flush occlusion. I'm really thinking about microchannels. Is there a microchannel here? And so this is a crossing where I used an 014 to start to get into what I thought was the true lumen, and then use a stiff angle glide and cross subintimally. So I didn't go off into Never Never Land. I started off in the 014 and then went over to an 035 and crossed subintimally. Treated this with shockwave in a standard fashion, and you can see exactly how calcified that shockwave balloon. This is actually one of our first cases using IVL. You can see quite how far outside the probably true lumen I really was using that shockwave balloon. And just the expansion of balloon is relatively challenged even after treatment using shockwave. So here we go with a runoff. This is after shockwave alone. Relatively good flow. This gentleman thought, okay, well, we'll do some post-shockwave. There's lots of dissections. You got to take multiple views. One view is no view. And when we used here, I went on to do additional vessel prep with an angioscope or chocolate balloon. I generally like chocolate here. I really initially poo-pooed this thought, but then I read Mehdi's paper on it, and I thought, okay, maybe I'll try this. I need to prep prior to DCB, so used more DCB here from basically top to bottom. And the final result, though not perfect, was decent, and I try not to put any scaffolding in there if I don't have to, and so Benner's the enemy of good. I walked away from this, and you can see, I don't know if we have the, yeah, here's the angiograms here. This is not perfect. There's lots of kind of linear dissections, but it's enough to walk away from. And just an FYI, I went back and did a repeat angio on this person 3 years later, still wide open. So positive remodeling, patient done well with DCB, never had put any scaffolding in there despite very, very heavy calcification. And so I don't think we're not in the process, as Chris White would say, the beautification of arteries. We just need to get it open. Here's another case, second case for 3 times the charm of a 76-year-old with, again, usual stuff. Again, trying to do a crossover to a mid-SFA, cross with an 035 wire, and I'm just going to skip through here. Key thing is if you're going to do atherectomy, understanding a difference between your crowns, your classics, and your solids, which is debulking, which one is polishing, which one is micro, and understanding your orbital sizes. If you don't have one of these charts in your lab, if you're going to do CSI, understand how big it's going to go, and because the heavier the crown is, the bigger it's going to go. And so here's a case example of using atherectomy in this SFA popliteal, distal P1 to P2 segment, and this did fine with just angioplasty alone. This is the 3 times the charm case. This is an 85-year-old, and usually I'm not up for intervening upon 85-year-olds, but this is an 85-year-old who really wanted to play golf, and he could not basically walk to his golf ball and hit the ball. And so he was extremely frustrated by this. He had a popliteal occlusion, underwent an attempt by vascular surgery, and then went an antegrade attempt approached me for a popliteal occlusion. Iliac stenosis had been previously treated. And really, I brought him back for antegrade and retrograde revascularization. So this is a rock pile. You can actually see in the far right panel just how calcified 85 years of love in there to try to cross this. And I had tried to cross before, got into collaterals, could not get in through this vessel despite being antegrade. So I have all the force possible coming down and just could not get through it. So I brought him back for a third attempt, one with a surgeon, second time with me, was able to cross retrograde. Treated this with shockwave. By the way, to just get balloons through, I had to use a 1.5 millimeter coronary balloon, and then up to a 2, up to a 3, up to a 4 sort of idea. And you can kind of see this is the shockwave in the actual calcification. You can see how subintimal and spiral we were. And then finishing up with the CTO with essentially with Superistent. And even though it looked, I would say that even though it looks like you can see the calcification there, you can actually see the calcification. The flow is great. He's doing well. He's walking well on the golf course and not having any problems. Offered to take me out for golf. I said, no thanks. I'd rather not lose money against you. So my tips and tricks for treating calcification is CSI, if you're going to use it, use Glide Assist. It's a nice way to get your device there. Lots of flush. I put in vasodilators. You can use TurboHawk for severe calcification with focal lesions, IVL for the M5, and if you don't have the M5 Plus now, it's great for efficient and effective treatment. And then I try to use additional prep. I really try to get these things expanded before dealing with the calcification, and I'll use chocolate or angioscope and additional. I really use EPD for every case except for IVL. And then kind of plug to some other operators here have been here today to use IVUS as well, because it really helps you understand what you're dealing with, understands your calcification. And if you're going to deal with SFA calcification, it helps to understand exactly what you're treating. So that'll say thank you very much.
Thank you. Thank you, Drew. To get an insight into your thought process and mind is probably the most interesting part of these cases, and thanks for sharing that quite clearly. Let's move on. Let me invite my dear friend, Dr. Mahesh Anantha Narayanan, to talk about below-the-knee intervention. Again, we are hoping for some cases that will build and strengthen our characters. Anantha?
Do these cases the way he danced, I think we are up for a blast.
Thank you so much for the opportunity having me here. It's a privilege to give a talk in CVA conference. Oh, I see. Okay. Thank you. So today, my topic is to talk a little bit about tough cases that build character with respect to below-knee interventions. As we all know, like, we come up with this dilemma below the knee and where to intervene, when to intervene, what all devices to use. I just want to go over a few cases and start with what I usually do, and finish up just showing some of the complications that we had too. So golden rules to remember for me: one vessel runoff is better than zero vessel runoff. Tibial artery revascularization is better than peroneal revascularization. And angiosome-specific segment revascularization will lead to high limb salvage. So understanding the concept of angiosomes might help, especially when someone is having a wound in the tip of the toe or a lateral aspect or medial aspect. It's nice to know the posterior tibial supplies to your plantar and medial heel, and the peroneal supplies to lateral and lateral heel, and then the anterior tibial supplies to the dorsum of your foot. There are a lot of data. There's a lot of data on below-knee interventions. I just wanted to show a couple of the outcomes from meta-analysis, putting together all the propensity matched and randomized control trials so far, and it seemed like there is advantage using angiosomes and revascularizing based on that, and that shows that your major amputation rates and wound healing is much lower when you revascularize based on your angiosomes. There's a lot of advances in the field of below-knee intervention, I would say. We do have techniques that we're using that we never used before: long balloons, high-pressure balloons, low-profile balloons, and shock waves, all microcatheters that we use, and pedal sheets. And there's a controversy about using stents below-knee intervention, and there's enough data on that. There is still more data to come, but at least from what we know, there is some amputation-free survival advantage from the PADI trial, 5-year follow-up. At this point, I prefer to avoid stenting above and below knee as much as possible. Our location of lesions sometimes will help us identify. Always do a CT scan before we go for any below-knee intervention on patients. And as you can see, the combination of anterior tibial and popliteal turns out to be the most common presentation, followed by multivessel disease below the knee. Sites that are used to access distal AT is a good way of accessing it, distal PT. Lower interosseous membrane of PR, it's a very challenging access. The vessel tends to move in the membrane, it's difficult to access, but as long as it's a thin individual, you can compress and you can still access that PR. And proximal 1/3 of AT actually is a very good area to access, which I've done 1 or 2 cases like that. Things I try not to do in below-knee intervention: dissecting with antegrade dissection and re-entry all the way into the mid-distal vessel, so we'll lose that. Leaving a perforation uncontrolled, saying it's a small vessel, it's going to stop. Sometimes it can lead to compartment syndrome, and that's important to stop a perforation. And try to avoid chasing below-knee interventions for people with Rutherford class 3 or below. And stenting below knee at this point, as I said, I'm not a big fan, but I'm still waiting for more data and trying to see if there's anything that comes up game-changing in the future. All right, so we'll start with cases. I have a few cases that I'm going to show. Case 1 is a classic example of multi-vessel below-knee disease, and this patient has a 74-year-old female with non-healing wound. non-healing wound on the heel as well as toe ulcer, first and second toes, and her ABI on the right lower extremity was 0.6. I'm going to let these pictures play so you can look at it. So as you can see, she has diffuse SFA disease, and then there's not much popliteal disease. Below knee, you can see all three vessels are diseased. This is pretty classic. There's no CTO. It's all multi-level occlusions, but she has two wounds corresponding to the AT as well as PT. So we ended up atherectomizing, used a Pantherus for the fibrotic SFA changes. I tend to avoid direct balloon dilatation of small vessels like this that can lead to multiple dissections, so I try to just shave directionally, like I use Pantherus to just shave off with the filter. And once after we got that done, then we did a balloon intervention with sorry, that didn't play well, I think. And I have to. So I just did ballooning of all the vessels, and then I wanted to show you the final outcome, but that slide is missing. Sorry.
No worries. Keep going.
A lot of slides are missing here. So we had a 73-year-old male with a non-healing first toe wound with ABA of 0.6. I wanted to show you the picture again. That's missing for some reason. This AT vessel. Is there an image to play there? That's an image. That's. I think it's missing. Okay.
Well, you will have to describe as the angiogram. Go for it.
Yeah, just keep going forward.
Yeah. I think we had a balloon intervention for this AT that was missing, and then we tried coming from above, and that's just an injection to show that we were in a dissection plane, and we were getting access from PT, and we were getting through a collateral, the lateral plantar artery, and we were able to enter the AT from below and revascularize that AT, so we got to a cell runoff to the leg from that. A lot of slides are missing like that.
Don't worry. I will personally review it with you.
Okay. There's a 76-year-old male with right lower extremity non-healing foot ulcer, ABI 0.6 and TBI, now the images are playing. And we come up with complications like this, and this is just AT, I revascularized the AT, and I wanted to just stop, but the guy's wound was in the lateral aspect, more of the posterior tibial wound, so I just wanted to revascularize that. Thought we'll just get it with the microcatheter and a wire, but we were not able to, and unfortunately sometimes overconfidence can get into trouble. And we got into that track and went into a subminimal plane and just came out of the vessel and started perforated bleeding like that. We harvested some fat. We tried balloon tamponading from above and then entered from PT. And we ballooned open the PT into TP trunk, and then we were tamponading that, injected some fat from the left groin, harvest, and that kind of appeared to stop the bleeding, but it kept bleeding more after some time. So we ended up coiling that and getting taken care of and establishing two-vessel runoff to that to the foot. Oh, that's some image. That's positive. So we're trying to access the PT from here, and this was difficult to access. So we had to go RAO, LAO just to see the trickle and just to do both ultrasound-based as well as based on fluoroscopy. And once after we access, that's where we're tamponading the bleeding spot, and we are in the PT now. So trying to stop the bleeding here, but it still kept bleeding. So we ended up. This is right after fat embolization. It appeared to be stopping a little bit, but it didn't. So I ended up deploying penumbra coils and then did some packing coils in there. So it still kept bleeding, so we went for coils. And after packing coil, we had a two-vessel runoff to the foot, and then this bleeding spot has stopped bleeding. And we had a two-vessel runoff to the leg at the end of the procedure. And then I just wanted to quickly show you this last case. There's extensive calcification. We just talked about SFA calcification. Sometimes you get cases like this, difficult to even advance sheath, get anything down there. And this vessel I was trying to show basically because we tried coming from below and shaved that PT, alt calcium, and then I lost an outflow. So it's important to not end a case with a lower outflow than what you started with. So in this case especially, there was two-vessel runoff initially, and then I lost the vessel at the end of the case. I had to go back and open that vessel and atherectomize the PT as well as PR to establish two-vessel runoff. This is a pretty difficult SFA case, like where we talked about some of these rocks that we see every day, and tried getting up with a reverse cart, shockwave, atherectomy, everything, and finally able to establish flow, but then the flow was pretty slow, mainly because we knocked down the second vessel down the leg. And this is after atherectomy, the second vessel goes down, and we revascularize right after to establish more flow. That's probably getting done almost. So this outflow was right after we opened up everything, and I thought it would be pretty brisk. We lost the second vessel there, and then we opened up with better outflow after we opened up the second vessel. So anytime you're trying to do anything above the knee, trying to protect your below knee, and making sure the outflow is okay at the end of the case is important too. That's pretty much it. And this is an acute limb ischemia. I just wanted to end saying below knee intervention, not only for critical limb ischemia. For acute limb ischemia, it's important for you to establish outflow. So for some of the cases that we had, we really had to go down below the knee and balloon all the vessels. Creating a channel through ballooning will actually help more outflow in the vessel. So that's, in acute limb ischemia, I try to balloon all the vessels below knee if there is a lot of clot in there. And this lady had a pretty good outcome after balloon, and you got flow through the rest of the vessels. And finally, I just want to conclude saying below the interventions are critical in patients with CLI, and having the right equipment for below knee revascularization makes life easy. Revascularization based on dermatomes is important, and as I say, one vessel runoff is better than zero vessel runoff. Again, thank you so much for the opportunity, and sorry about the slides that we missed, but hopefully we can get it back next time.
Absolutely, absolutely. Thank you, Amanta. I think just, I also have a lot of challenges with below the knee angiography for patient movement. Still, images are actually always convey the message and are also expeditious. So in the interest of time, we'll move on to a very challenging and hopefully a character-building case from Dr. Ramon Varco from Australia, from Sydney. And he's going to talk about popliteal CTO. Ramon, you're very welcome to be here, and we're delighted you can join us.
Thanks, Subhash. So this is just a challenging femoropopliteal case I thought might be of interest. These are my disclosures, none relevant to this particular presentation. So this case is a 71-year-old man who presented with CLI affecting the left foot, gangrenous toe tips, and also a shallow heel ulcer and ischemic rest pain. A fairly comorbid gentleman with renal impairment, congestive cardiac failure, ischemic heart disease, type 2 diabetes, and obesity with a long history of cigarette smoking. This patient had a previous long segment SFA stenting and also a popliteal stent, which had all become occluded, and you can see that from these images here. So these are obviously a very calcified femoral SFA with a stent which has become occluded. You've got profunda runoff, and then you can see a CO2 image on the right showing also that there's an occlusion in the popliteal artery stent with impaired runoff below the knee. So this is a patient that failed from an antegrade approach. As you can imagine, these Tosaka 3 lesions are often very difficult to pass wires from an antegrade direction. So here we've done a retrograde puncture through the occluded stent, which I spoke about on Thursday, is a technique we use quite frequently. The way we do this is a combined antegrade and retrograde access. You can see the stent quite clearly on fluoroscopy, and you can puncture it with a standard percutaneous entry needle, and then usually you use a stiff angle glide wire to form a loop which traverses the stent. And once you've done that, you can capture the wire and externalize it, and then pass a catheter down from above before reversing that wire to then traverse the occluded stent. In this particular case, and you do this with a very straightforward supine position with the hip flexed and externally rotated, and then the challenge here was then traversing the popliteal artery. So here what we've done is we've punctured the distal popliteal artery from a retrograde position, but we've done it by puncturing from an antegrade approach, in an antegrade position by rotating the C-arm to separate the bones and then puncturing between the tibia and fibula to the distal popliteal artery. And you can see that here in this diagram. It's done with a micropuncture sheath, a micropuncture needle, and then you introduce a micropuncture sheath. And in this image here, you can see the Apanova sheath from the contralateral femoral access. You can see the sheath that's placed through the occluded stent, and you can also see the sheathless approach that we've taken to the distal popliteal artery, and also the CO2 canister there. This was the final image here after balloon dilatation through the occluded segment of sheath, a stent in the femoral artery and also the popliteal artery, with a very good outcome in the end. Thank you for your attention.
So I think in the interest of time, I'm going to ask the panelists to opine on their favorite calcification tool. Bala, I know yours, but you can articulate why, and as a surgeon, you have adapted to your endo techniques and modified them based upon availability. So what's your favorite calcification device, and how do you approach dense calcification?
Well, it depends on the location. If it's common femoral and profunda, I still prefer to do open surgery, especially because it's important to preserve the profunda. Now, if you're talking just endo and SFA, I prefer actually shockwave now for heavy calcification. I've also found that it embolizes less, and I don't have to use a distal protection device, so I prefer shockwave.
We can go down the line. Drew, very quick comments and any
Yeah, I
thing
think
you want to identify.
for, I actually do the common femoral and SFA and profunda with shockwave. I've definitely switched over. It's a lot faster, especially with the M5 Plus. So much nicer.
Phil, you can't say scalpel, but other than that.
I tend to favor sort of the low-profile CSI. I'm not so sure that whether rotational atherectomy or lithotripsy or anything is better one or the other, but CSI goes through a really small puncture, so the likelihood of having access complications is lower. So I'm trying to keep it simple.
Jennifer?
Yeah, I'm with Phil. So I do like shockwave, but sometimes it's a little hard to pass. So I still do use CSI pretty frequently.
Yeah, same thing with me, CSI and shockwave.
Maybe, what is yours?
For calcification, for below the knee, I am more orbital. Also, although I be honest with you, lately, I feel like, we can get good results with balloons. I think, IVL is useful if you have circumferential calcification. I don't think it does much if you are subintimal, and if you have eccentric calcification. Can I move to another question? I was going to move to the BTK, and we talked about complications, and we saw a perf. Maybe as Mazen, since you wrote the complication book, Mazen, we're going to start with you. So for BTK, sometimes you have wire perforations, sometimes you may have perforations like the one we saw. What is your algorithm? And if you can focus on it, because I think sometimes we overreact. To be honest with you, I mean, what are your thoughts on your?
Yeah, I want to make sure people know I wrote the book, but I didn't cause all the problems in the book. I mean, it's like this is becoming a little bit.
We heavily contributed to your book.
We all did.
We all contributed to your book.
All right. So yeah, great question. So I did actually a complication lecture yesterday on peripherals, and part of them was below the knee, but it depends where. If something you can control with manual pressure, I've used an external blood pressure cuff inflate for 5 minutes on multiple, not only wire perforations, but also device perforations very successfully. Without reversing heparin, without even, if I have other wires, I don't even remove the other wires, and then I can continue with the procedure. Some of these were like ocelot perforations or some other perforations. If it's in a place where you cannot control the bleed, I always try, because sometimes you think, this is like peroneal, you cannot get it controlled, but sometimes you put supra, and remember, these are vessels, most of them are anyway occluded, the pressure in them is not that high, and sometimes all you need is a little bit of an external pressure over a big area with a blood pressure cuff, and it takes care of it. If not, prolonged balloon inflation has almost always worked. I've never placed a covered stent there or anything like that. Sometimes, it messes up your intervention and you have to come back at a different day, which is perfectly okay. I always say and tell my fellows, you can always do more later. None of these procedures are life-threatening. If patient comes back next week for a reattempt, it's okay.
Good points. I think there's a question from the audience. Please go ahead and introduce yourself, please, first.
Yeah, great case. For the case presented about the gentleman who liked to play golf, and there was a big calcium nodule, you were able to cross around it in a spiral way. I have a question for the experienced interventionalist and also vascular surgeon. Would you, in this case, leave it alone, come another day, Would you like to decrease the in-stent restenosis, put Supera stent? Or the third option, would you put a Viabahn stent from healthy segment to healthy segment? Thank you.
Yeah, so to decrease restenosis, I actually did pre-treat with a drug-coated balloon, and then I put a Supera stent, and then aggressively post-dilated, and then did IVUS, showing good stent expansion. So to really maximize it, it looked horrendous because of the calcification over the vessel, but that's what I did in that case. I don't like Viabahn in that case just because I hate, honestly, I can't stand the whole, when Viabahns go down, they go down so hard that you've gone from clotting into acute limb ischemia very quickly, and I thought a Supera stent in his case would do well, and I followed him with serial duplex, and that's now 2 years ago, and he's doing quite well.
Can I just ask another just follow-up question? With these Supera stents, do you like overstack them in these heavily calcified areas, or you're always, always like deploy them normally?
I try to overstack them extremely. I mean, as much as you can. I'm still waiting for some great ability to change the deployment mechanism of that stent, so it would be a lot easier. It's just really hard because sometimes you can overstack, and sometimes you're pulling back and the patient moves or whatever, and you just don't get good expansion. But I do try to overstack and try to appropriately size. So I use the 6.5 there as well.
One thing that I would just add, for the Supera, as Drew said, you have to really prep the vessel. And what I've seen is that because you're in a spiral dissection and you have calcification, folks are a little bit concerned or conservative in getting the vessel prepped. And then what happens is that they either put an undersized Supera, or if they use the right Supera, they get elongation and they get into trouble. So I would say that if you're going to put a Supera, you need to not have fear and go for it, meaning that prep the vessel correctly so that you can deploy the Supera appropriately. Otherwise, you will get elongation and get into trouble.
Yeah, and that's why I used the Shockwave, then went back with a chocolate balloon to maximal pressure.
That's exactly right. Even though he was subintimal, he used the Shockwave because he knew he had to have a good, that's a good point. Subhash, you have a question?
No question. I just have a comment because I think we have spent a perfectly good hour discussing these cases. We have tried to intentionally emphasize the interface of interventional cardiologists and surgeons. And I think these cases do highlight that collaboration, especially for the aortoiliac segment. I also want to say, with not at all with the intent of stirring controversy, that there is a change in the paradigm how STEMIs, hopefully in the future, are going to be treated. That is, to unload first before reperfusion. That has got immense consequences. How interventionalists in the future are going to get more comfortable with aortoiliac accesses, large bore access in a more stringent setting where the response time and device compatibility issues, lack of imaging may all come into play. So we are heading for a very interesting time, and I think that these learning tips from our colleagues are going to be very meaningful. Zach, you have a comment? Please, go ahead.
It was going to be a little provocative, and the interventional cardiologists up here commented on the fact that all of the STEMI data coming out now shows that a radial first approach has a higher or has improved outcomes. Nobody can totally explain why, but I don't disagree with you about the unloading part of that too. So, and especially as we move towards radial first, and then we talk about our fellows not having good femoral skills, all this is just really important going forward.
All of these are very pertinent points, things to consider, but then things to deliberate at our next CVI conference in Austin in 2023, and also at the case competition session that is going to follow. The fellows have prepared a fantastic array of cases. I can tell you it'll blow your minds away. So if you can grab lunch and join us there, that would be fantastic. Mehdi, over to you for final words.
No, we have time, and I like the discussion, so I was going to ask one more question. Is that okay? Because we have 5 more minutes. We usually are late, but we are ahead, believe it or not. So can I ask one more question for this? I want to learn. We had a nice case of kidney transplant, and I just want to pick on on the panel, and see, what their thoughts are. Do they completely stay away from it? Bala, what are your thoughts? Do you, in regards to these folks that have kidney transplant?
Yeah, generally I try to avoid accessing the site that the kidney transplant is. I try to, as much as possible, to go to the contralateral side. Because first, if you have a problem with that iliac for whatever reason, then the transplant is at risk. And that's probably the worst thing that can happen to the patient. So I try to avoid the ipsilateral side.
I think it's a big deal. It's a big deal. And if there is any way to stay away from the transplanted side, you know, you should try to do it, because if there is a hematoma or any kind of a complication, it could compromise the kidney.
Mehdi,
Dr. Castro.
one
Yeah.
suggestion to you is that for CVI 2023, I've done a lot of renal artery transplant interventions and interventions to the common iliac above, leading to acute, basically acute renal failure or hypertensive urgency. So there's a lot of opportunity for us peripherally trained to understand this realm, and it really can make a big difference for these patients.
That's right. It's not that common, but it can have huge implications. I agree with you. Dr. Castro.
Just have a question regarding the use of IVL in subintimal space or total CTO, or even for like an underexpanded stent, like due to calcification.
I don't know what Drew will say, but most of us are getting more and more comfortable of deploying IVLs in subintimal space. So, Drew, do you agree?
I have no problems in using IVL in the subintimal space, and it really does help out, I think, in a lot of ways. As you saw in that case, it was very subintimal, very subintimal, and I think it does I think it makes a difference because you're cracking calcium on the other side so you can get better stent expansion. That case was an example for me. I'd never encountered truly on IVUS, and also in the case, calcification of that level, and the IVL really made the difference there.
Let me end with some disclosures that my worst complications for the aortoiliacs have been in not identifying, and let me say this, accessory renal arteries coming out of the distal aorta. And I think CT imaging is extremely crucial for that purpose. And the second major complication that I cannot ever reconcile with is a hydrophilic guide wire perforation of the renal capsule by advancing and not following and tracking. And I think that those are very simple things, and then again highlight the fundamentals of intervention that many of these experts have shared today.
The IVL, I'd like to make a comment about that. I don't think it helps that much, in my opinion, in the subintimal space, because when you dilate, you're going to dilate towards the least resistance. So I haven't found it, honestly, helpful. I think even in the stenotic and calcified lesions, it's not helpful unless you have circumferential calcium. Just my opinion, and I don't know, I'd love to see data for subintimal space, and those kind of things.
I think Mehdi is absolutely right, because the word subintimal is quite a basket full of terms, and where you are in relationship to the lumen may matter. So I agree with that it may have limited use if it is through the medial deep calcium, but not subadventitial.
Okay, well, it's okay with everybody on the panel, and thank you so much for being here last session, and looking forward to 12:30 and lunch. Thank you. Thank you.
This is, I'm telling you.